Yeah, good afternoon to everybody. Thank you for inviting me to present some ideas about patient safety and the way that and the need for research and synthesis in France, and perhaps in a larger scale than France, because the questions are the same everywhere. To start with the definition, what is patient safety? I don't know the level of knowledge of the audience about patient safety, so I start with the definition. The one of the WHO, which launched a classification in 2009, saying that the patient safety is the reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. So that's the definition. And you can see on the right the conceptual framework which is associated with this definition, saying that if we, and I think that's a good start to deal with the patient safety research question afterwards, because you see the whole picture of what is behind the term patient safety. So you see at the top of this figure that patient safety deals with identifying incident. Incidence is the generic terms covering the incidents with clinical consequences, adverse event, the term is adverse events, and incident, so dysfunctions or errors without any medical or clinical consequences, and the term may be error or near misses, etc. So incident is the generic term covering everything about error, near misses, adverse events. So and then below you can see that we to deal with patient safety and to risk manage things, we have to detect these incidents, to mitigate the consequences of this incident, to lower the patient outcome, the patient consequences, and also to lower the organizational outcomes. And at the end, we also have to implement ameliorating or preventing actions in order for this error or adverse events not come again. So patient safety research deal with all these different steps in this conceptual framework. In a large approach, patient safety research is part of what we call also improvement science, which is nicely presented by the Institute of Healthcare Improvement with his model. We always ask 3 questions in the improvement science. The first one being, what are we trying to accomplish? What is our goal when we treat a patient with coronary heart disease? What do we aim to do? And the second one is, how will we know that a change is an improvement? Because patient safety research or patient safety activities aim at making change in order to prevent incidents. So how we know that a change is an improvement, and what change can we make that will result in improvement? So that's the basic questions that we have to answer and research has to deal with. What is patient safety research? If we look at it from the WHO point of view, that's a very pragmatic approach of what is called research, and a lot of activities under the term research is not what we would call what we would name research. It's, for example, just simple epidemiology to count things. So you can go on the website of the WHO to know what WHO is doing under the name patient safety research. I will go a little bit beyond and give some examples for France of what has been done or what is currently done. some epidemiology, which is not properly researched, which is we try to count adverse events or healthcare associated infections or anesthesia related events. All these studies and surveys that are implemented from time to time to know how it happens and how much we have. Health policy research, very limited things in France. To my knowledge, there was only one study in order to know the perceived impact of French national safety initiatives. That was this study was done in the same time that the NAIS-2 study, in order to understand why the indicators measured by the National Survey on Adverse Events have moved or not. So this perceived impact study was done with economic and human science researchers. We also work on tool validations of indicators, and I should mention the Clarté program, which is led by Cyril Gaulin. We are validating indicators such as the patient safety indicators for France, or safety indicators in safety culture. We also validate questionnaires, and I have mentioned only one of them. Intervention. Now, intervention assessment. There are, in fact, a lot of works dealing with the aim to decrease complications or improve quality of practices being tested, being studied as intervention, such as educational programs, simulation, human factor-directed interventions, clinical systems, such as telemedicine, does it decrease some complication, etc. And the so-known multifaceted intervention, we spoke about it before. So decrease complication, improve quality, also improve safety culture, which is another field, another aim. And also we have some research studies on scenario already done or surgical checklist. Does it increase safety culture? So that's some pieces of work that is done. This is, I should mention also, but I don't know them, all the studies that are in clinical research dealing with the effectiveness of intervention, which from time to time also have goals including safety. But it's very hard to identify all these studies. Why is it hard? Because you see here the organization of research in France, and that's quite a simple picture to give you an idea that it's not so easy to know where and why and how to finance, to get money and to make research simply. The second slide is perhaps even more complicated. You have here all the institutions, and some are getting together, but it remains quite tricky to see how to be financed and to implement research. And that's for biological, all the biomedical research. If we go to health services research, which is very important, but very poor in France, it's hard to identify things in this picture. If you go more in depth in the health services research into the patient safety research, now you find some 10 or 20 thousand euros per year to do research. That's not the hundreds of, so not the millions that are available in the US, for example. So we are in France not in the pace to give some priority to this type of research. However, you perhaps know that this year the Ministry of Health is building a national program for patient safety, and one of the four approach is about research. So perhaps we will talk about organizing research, and perhaps we will talk also about financing research, but the time is not very relevant for that. So now some words about the challenges in patient safety research, which I think it's absolutely not original or for in health services research, but I give it to you. The first not specificity, but the first issue is when we speak about intervention research, the type of intervention. We know, and Cyril asked the question, what about the multifaceted intervention to increase safety? We tend to think that multifaceted interventions are more efficient or more effective. Although I agree that to get results, we have to very thoroughly think about the relevance of the intervention and the way they can complement themselves. If we put multifaceted interventions on the same topic, which is education, or I don't know, then we won't get a better result than one facet research. So in patient safety, we often have multifaceted. That means that that's on the right of the picture. We have to direct intervention to education, to diffusion of protocols, to involve patients, which is critical in patient safety, with on computerized registration and feedback system, and on process and outcome indicators. We have to put our effort on all these dimensions to get an effective intervention. And we will see afterwards why we should need these multifaceted interventions. In addition, you see in the title, multifaceted tailored implementation of bundles. What is a bundle? The bundle is a series of intervention on different topics. And you see here that they decided in a ward or in a group of wards to improve patient safety in tackling at the same times falls, pressure ulcers, and urinary tract infections. So then for that you need a bundle of interventions, bundle of interventions. The third specificity, which is perhaps specific for patient safety, is that we almost always need cluster trial, because the intervention is not at the level of the patient, but at the level of the organization, because intervention target organizations. And then we have to do cluster trials, which increase the level of complexity. What we talked about before, and which is also very relevant in patient safety research, is what we call often the black box. What is the black box? I tried to illustrate the black box using this result. So in the UK, the Ministry of Health implemented a national patient safety agency some years ago, and this national patient safety agency implemented a very large incident reporting system. They wanted to have all the information about all incidents in their country. And the context was that the Ministry of Health Department of Health was very critical to what they implemented some years before. And researchers were committed to see if increasing incident reporting what was in relationship to better quality and safety. And the result is, you have it here, that if the number of incidents reported increased with time, number of months live of the incident reporting systems. So it always increased, but it was not related to any of the outcome indicators, and it was, though, in terms of safety, and it was only related to the safety culture of the teams. And this is tricky to interpret. This is very tricky. Why do we think so little things, whereas they put billions in these systems? Because of the black box. What is the black box? Incident reporting is an intervention. An intervention that aim to make people, frontline workers, nurses, doctors in the you know that, in the wards, bringing information about the problems they have in their own setting. So that's an intervention in itself, because if they know what happens wrong, they will perhaps change. And if they, and the only fact to report something make change. So this is an improvement effort. We know from the literature that the factors to predict a successful outcome of improvement efforts are numerous. This study retrieved 18 factors related to who mandate for change, the leadership, the support of champion of leaders in the hospital, the involvement of middle managers, etc., etc., etc. That means that if you don't get if you don't improve the situation after the intervention, you just have to come back to these characteristics and try to understand why it didn't improve. So that is the most difficult area in the patient safety research. If you don't know what is in the black box, you hardly are able to interpret the results in terms of external validity. If it has worked, or if it didn't work in one setting, is this results applicable outside? So that's the big difficulty. For example, I show you here some 2 slides about the drivers of quality improvement success. So everything participating in a quality improvement intervention has to document interventions on and drivers for the success are 8: choosing the right subject, quality improvement knowledge, successful data collection and improvement, characteristic of the organization, and you see all the variables they should measure to understand properly the things, and participant recognized benefit, connectedness with network, choosing the right team, and sufficient resource and time. So the idea is that in patient safety research, either you collect all this information and giving questionnaires to everybody and asking to give hundreds of answers to better know the situation, or you use qualitative methods. Using qualitative methods and also quantitative, because you know you want to address the questions of the effectiveness or of the efficiency, need to connect results from the qualitative field and from the quantitative field. So that's a usual challenge in the patient safety field. For example, we just are a part of a DUQue. The DUQue project is a European project that try to answer the questions of if we have a good quality management team or organization in a hospital, do we have good results at the end in terms of outcomes, quality and safety outcomes? In order to answer these questions between this box and this one, we have to take into account all these other pieces of information. You understand the difficulty? So that's some thoughts about the specificities or in patient safety research. The last part of the talk is where can we find evidence coming out from the patient safety research. So historically, the first evidence came from reviews done by the Agency of Healthcare Research and Quality from the US, and they reviewed all the literature about clinical practices and the link between clinical practices and safety. And you see it here, 11 things that should be done everywhere because it's highly related to safety. Afterwards, we had a large set of research. During the year after 2000, which put more emphasis not on clinical practices but on organization. For example, we had a publication in the New England Journal of Medicine about the surgical checklist and its efficacy to reduce morbidity and mortality. We had the impact of quality improvement collaboratives. We had also the effect of what we call executive workarounds on patient safety climate or culture. So this type of interventions that are more directed to organization than to patient management. So I give you the example of another review that was published in 2008 that again found that the clinical practices were also very related to improvement of safety, but also organizational interventions. So we have now, from the reviews, I don't speak about Cochrane, but from reviews done by individual or independent researchers, some information about that. But I think that the most frequently used source of information comes and used by the professionals comes from websites such as this AHRQ, so this Agency of Healthcare Research and Quality in the US, which is a little bit like the HAS in France. And the information here is not synthesized. So each agency is putting one article or the other, and people who want information, they will just be given this information. Code bar technology on the safety of medication administration is good or not, is efficient or not. So that's one problem. The other one is that people that search for information for their daily practice won't go to the reviews, but they will go to what the patient safety agencies diffuse as information, which is a very simple information without the background of all the research that is behind these recommendations that are given. So people depends on the quality of this work that is translating evidence. And they don't have the information from the researchers. So now we come to Cochrane, and perhaps this is the aim of the discussion. What has already done Cochrane that we could directly relate to patient safety, the patient safety field? Thanks to Pierre, I got the list of the 2012 works that have been published. Some very few are directly related to patient safety. The first one, interventions to improve hand hygiene compliance in patient care. It's obviously patient safety related, because if you don't wash your hands, you will get, or you will bring infections. So that's patient safety very clearly. The effectiveness of shared care across the interface between primary and specialty care in chronic disease management is also related to safety, but also to quality. I don't want to make too much difference between safety and quality, but it's related to avoiding adverse events anyway. We have also reviews about organizational interventions that I have given here as examples. There are others in the list. Effect of outpatient pharmacists' non-dispensing roles on patient outcome and prescribing patterns. All the electronic intervention, retrieval of health information by healthcare providers to improve practice and patient care. Intervention for promoting information and communication technology adoption. You see that these are interventions that are partly related, indirectly related to patient safety. My opinion is that till now, the Cochrane has perhaps disregarded the field of patient safety, where a lot of information are published every day, and people are till now more dependent on sources of information that are not related to a proper synthesis of the literature. So that's perhaps why you asked me to look into the list and into the sources of information regarding patient safety. And that's, yes, some part of conclusion that I could say. I don't know how AHRQ could answer to that question, but my impression is that there is some margin for improvement in that field. Thank you for attention.